Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. I am so glad you are joining us today. We have two amazing guests with us who are going to help us understand PET scans. In fact, we talk about other type of scanning modalities. We are going to hear from Dr. Kiser, who works in nuclear medicine, as well as Pam Kohl, who is an amazing patient advocate living with metastatic breast cancer. We know that breast cancer is challenging, and accurate diagnoses and staging are critical for effective treatment. Nuclear medicine has revolutionized this process by providing detailed images of how our body functions, which is essential for detecting and monitoring cancer. FDG and FES, also known as Cerianna PET scans, are among the most advanced tools we have. These scans use small amounts of radioactive tracers to highlight cancerous tissue, offering a non-invasive way to see what's happening inside our bodies. Before we dive into today's episode, I just want to give a shout out to our friends at GE Healthcare for their continued support and dedication to the work that we do here at survivingbreastcancer.org, and in particular, our podcast, Breast Cancer Conversation. So thank you, GE, for being dear friends of our organization. Now let's get started. Welcome to the conversation. I just kind of want to start off this podcast today with just welcoming our two amazing guest speakers who actually know each other through an op-ed article that they wrote, which we are going to get to later on in the podcast. But it is my first time meeting both of them. So we have Dr. Kiser and Pam Kohl joining us today. And we are going to talk about all things, I would say, like kind of scan related to PET scans, but then also maybe dabbling into like other types of modalities. So we're here to answer the questions that you guys send to me, that I receive in my inbox, that I receive in my DMs, and it is my job to go out and find the answers for you. So welcome to Breast Cancer Conversations. Dr. Kiser, I would love to turn things over to you to do a quick intro, like where are you calling from? What is your title? What institution are you with? What do you do?
So I'm the medical director and section chief of a hospital organization called Carilion Clinic. We're based out of Roanoke, Virginia. I've been the section chief there since 2015, and we've really grown a lot. And this area of medical imaging has really exploded over the past decade or so, because it's both imaging and therapeutics that are happening right now, because everything's kind of going to be like receptor based, which we're going to get into later. But with receptor based therapies, you kind of can, you can kind of avoid like the collateral damage that may happen with systemic chemotherapy. We're going straight for the target and not so much poisoning bone marrow or whatever else might happen with chemotherapy. So that's kind of our bent right now. We are building a new cancer center that's going to have the therapeutics and the diagnostics available, and really excited about that. In fact, they just had an announcement today about a huge donation from an anonymous donor. So we're going to hope to really break ground on this soon. Probably take about 5 years or so to build it, but so that's kind of my story of where I am right now. But we're continuing to grow and continuing to do new procedures, both diagnostic procedures with PET, as well as therapeutic procedures with what we call therapeutics, where you can take like an imaging agent and turn it into a therapeutic agent. So that's kind of what we're doing now.
I can tell already that I need to go grab a notebook and a pen, because I need to take notes while listening to all of this to understand the difference between, therapeutics and diagnostics, imaging, and kind of this merging of both of those fields. So I'm going to go do that. And I encourage our listeners, if you need to take notes, because I can already tell this is going to be such a rich conversation. Pam, I want to turn things over to you. You are, as our patient advocate and, friend joining us here on the conversation. Please introduce yourself, where you're calling in from, and a little bit about your breast cancer experience.
Okay, thanks. I'm delighted to be here. It's such an important issue for those of us living with metastatic breast cancer. I am Pam Kohl, and I live in Raleigh, North Carolina. And I was diagnosed early stage in 2009 early stage 1, small, less than a centimeter, no lymph node involvement, an oncotype of 6. So I had lumpectomy, radiation, and 5 years of endocrine therapy, and was told that my I could look breast cancer in my rear view mirror, that I was cured. 3 years later, I would go in for my mammography every year in October, and there was something suspicious in the same area of my initial breast cancer, and was told several times, we don't think it's anything, it's probably scar tissue, but we need to do an ultrasound today, right? Once you've had breast cancer, you sort of know what that means.
Yes.
And
My
so,
doctors tell me I get the special treatment.
right. And so I had the ultrasound. They came in and said, we still don't think it's anything, but we want to do a biopsy. And they did the biopsy, and then I got the call saying that it was just a recurrence of my ER positive breast cancer, HER2 negative breast cancer.
And this is while you were still taking endocrine therapy?
No. I had taken endocrine therapy for 5 years. It was,
and then you were off, and then
Yes.
3 years later. Okay.
Yes, 3 years later. And that they wanted to do a biopsy. I mean, a biopsy, let's see, that it was breast cancer, and that because I had radiation there, they were not recommending a lumpectomy, and that I needed to have the mastectomy, which I did. And the pathology came back a little funky. There was some areas that just wasn't quite clear, but it came back ER positive, and they said, it's just a recurrence. We're going to put you back on endocrine therapy.
Which endocrine therapy were you on? Were you on tamoxifen or?
I started on Femara, and my aches and pains were so bad. We ultimately went to tamoxifen. I was postmenopausal, so they just watched me like a hawk in terms of uterine problems and all of those kinds of things.
Right.
And again, I have no family history. I had an oncotype of 6, no lymph node involvement. So I suggested that maybe we should do a PET scan just to make sure. And no, you don't need to do that. We're very comfortable with just a recurrence and what we're going to do now.
And the PET scan, that's amazing to advocate for yourself and ask for additional testing. So was your mentality and thought process is it in other parts of my body? Should we do a more thorough scan? Is that kind of...
Exactly. Okay. At that time, I was working at Susan G. Komen, and I say all the time, the good news is I know a lot, and the bad news is I know a lot. And so I just, and they kept saying, you don't need one. This is just a recurrence. It's in the same breast. And I'm like, I think I need a PET scan. But, as patients, when somebody says, we're comfortable with what we're doing and you don't need a PET scan, that's sort of what you want to hear. That feels better. But my radiation oncologist called like a little while, maybe 2 weeks later, and said, I'm 95% certain that now that you've had the mastectomy, you don't need any more radiation treatments, but I want to take it to the tumor board just to make sure that everybody sort of agrees that we're in the right direction. And at that point, I really became fierce and said, if we're going to the tumor board, we need all the information, and let's get a PET scan. And again, you don't need one. I said, well, I don't think I need one, but if I'm back here in 5 years, don't we want a baseline, of a full body PET scan if I have another recurrence, or if I have breast cancer again in my other breast.
Yes. And just to quickly pause on the tumor board piece, and, Dr. Kiser, feel free to dive into, but the tumor board being, you're getting kind of that interdisciplinary perspective. You have your oncologist, your radiation oncologist, you have your surgeon, breast surgery team, plastics, et cetera, all there kind of looking at your case as a case study to determine collectively what the treatment plan should look like. So excellent.
Yes. So thrilled to go to the tumor board, but I just wanted all the information when they go to the tumor board. So she agreed to see if insurance would pay for it. And so she was able to get insurance to pay for it. And I had the PET scan, even though the day of the PET scan, we don't really like doing these because they're so sensitive. We get so many false positives, and then we're going to have to poke and prod you. Don't you just love that, Dr. Kiser? Um, and then we're going to have to go poke and prod you, blah, blah, blah. So I had the PET scan. 2 days later, 8 o'clock in the morning, I'm driving to work, and I get the call that, well, this is what we're afraid of. There are 2 areas that lit up. Now we have to go do biopsies. And we still don't think it's anything. So I had the biopsy. There were 2 lymph nodes near my lungs that lit up quite strongly. And because of where it was, I had to be put to sleep a little bit. So I had to be sedated for the biopsy. And in the afternoon, I'm in the outpatient waking up and all of those kinds of things. And my husband's there at 6:30 at night. And I see my oncologist and my radiation oncologist walking towards our recovery area. And I look at my husband at 6:30 at night. 2 doctors are coming in. I said, this is not going to be a good conversation. And they said that I had, they were shocked. They couldn't believe it. This, made no sense to them about how this could happen, that I was stage 4 metastatic breast cancer. And of course,
that was only found because of the PET, not because of any symptoms or anything else that you were experiencing.
Absolutely. I mean, I didn't even have symptoms. I just had my annual mammogram, which is, a reminder how important it is, even after you've been diagnosed with breast cancer, to continue being vigilant and being, trust your gut. It just wasn't feeling right to me. And I had to push to get the PET scan. Otherwise, and I know there's debate in the medical community about whether early diagnosis and early treatment of metastatic disease prolongs your life. That there was not real data to show that. But there's no way anybody's going to convince me that finding my MBC with only 2 metastasis instead of 2 years later or 3 years later with 10 Mets or 15 Mets that had now gone to my liver or important organs didn't make a difference. And I was told at that time that I had the average is 2 years, maybe 3. And in January of this year, I celebrated 7 years.
Amazing.
And I know.
That's huge. That's huge.
Right. And a big part of that, which we are going to talk about, is being aggressive with scans and then being aggressive when you find new mets.
So I got a question for you. When you got the PET scan, was your first PET scan, was it a Cerianna scan or was it an FDG scan? As FDG?
That was in 2017. And I had my first Cerianna in 21. And I was the 3rd person at my institution to get that.
It's only been FDA approved for like 3 or 4 years, to my recollections.
Just like a breast cancer diagnosis, we are already in the throes of alphabet soup. So we heard Dr. Kiser talk about FDG-PET as well as FES-PET. We're going to dive into that in a little bit. I also want to take a moment to note that if you hear us talk about FES-PET or Cerianna PET scans, those are one and the same. They're used interchangeably. FES and Cerianna. That is no different than how we heard Pam talk a little bit earlier about her hormonal therapy that she was on, the aromatase inhibitor Femera, also known as letrozole. So yes, the world of breast cancer, we have all new lingo, and everything for some reason has multiple names. Dr. Kiser, let's start with FDG-PET. Can you explain to us what that is?
So FDG stands for fluorodeoxyglucose. So everybody hears this myth that if you eat too much sugar, you're going to get cancer. Well, that's not true, but cancers do preferentially use sugar as their metabolic substrate, right? So like what we're giving this tumor is radioactive glucose, and it metabolizes just like regular sugar, except it gets trapped in the cell. And as it builds up in the cell, that's how we find hotspots on the PET scan. But it's not specific, to anything. It's not receptor based. It's just because cancer cells like to grow, and they like to grow fast, and they like to spread, and they like to do all sorts of nasty things. And FDG helps us find different things. But the problem is, it's not, like I said, it's not specific. It'll go to arthritis, it'll go to cancer, it'll go to infections. Anything that's using more glucose than it's supposed to, it'll go there. Now, that doesn't mean it's a bad tool. We still use it a lot for like triple negative breast cancer because we don't have any receptors to target. And it's a good way to follow patients clinically. But fluoroestradiol is a completely different thing, or Cerianna is the trade name. So we all know, or most, at least breast cancer survivors know, there's three major targets we look at, right? We've got ER positivity, progesterone receptor positivity, PR, and then HER2 new. Okay, and so Pam, you are ER positive, HER2 negative, and so that's a kind of the classic ER presentation. Because you don't want to be, because a lot of these drugs like Ibrance and stuff like that, you can't be HER2 positive, right? But anyway, so fluoroestradiol is a radiochemical that we use in PET that goes to those receptors that are the estrogen receptors on ER positive breast cancer. Okay, so that's the difference. So this is much more specific and targeted to looking for things that have ER positivity. Now, not just breast cancer has ER positivity, gastric cancer does. And there's others that have ER positivity. But the way we're using it and the way the label, the packaging insert says, is for imaging women or men, because men get breast cancer too, right, with ER positive breast cancer. And I can go a little bit further with that and say the advantage of that is, so Pam got her biopsy from where they knew the tumor was. And if she had it spread other places, well, the only way you know if all that cancer, the metastatic cancer, is ER positive is to biopsy every single spot. So what if you had like 10 spots in your liver or something, or 10 spots in your bones? You can't realistically go in and biopsy every single thing. So the problem is with breast cancer is you may have ER positive on that first biopsy, but within that tumor, there can be areas that are ER negative. And so if it metastasizes, then you could have, it's called heterogeneity. It means some are positive, some are negative. And the only way you can know for sure is to do a Cerianna scan. And that kind of will say, okay, well, this tumor in the liver is ER positive, but this one in the spine is ER negative. So you go on your hormonal therapy or whatever, your Ibrance, whatever, and you see some tumors stabilize, but then you see others progress. And that's because the tumors have ER positive and ER negative heterogeneity. And that's the problem, and the biggest advantages of using fluoroestradiol or Cerianna. FDG can't make that distinction. It can say it's tumor or it's not. It doesn't tell you anything about the receptor status. And so they're working. They've got agents in research that go to PR. They've got stuff. In fact, you've probably heard of Herceptin, which is a drug for HER2 positive disease. They can actually put a radiolabel tag on the Herceptin drug and go find all the HER2 positive disease. Now they're doing that in research now, and it's probably going to come to fruition. So there's off targets and there's specific targets that we can go to, and it's really exploding right now. And it's not just breast cancer; it's almost every single cancer that we have. In fact, we now have an agent that's coming out, and I'm not going to try to explain it, but we can actually use it in triple negative breast cancer because it doesn't have the typical receptors, but it's got some other types of receptors that we can go after. And if you can image those receptors, you can actually treat them. You take the imaging agent off, and then you put on something that's like an alpha emitter or a beta emitter, which are like radioactive particles that go in and just blow up the DNA of the tumor and just the tumor, and it doesn't cause the collateral damage. And so this is like the most exciting. I've been in practice for 27 years. And this stuff is just like the most exciting part of my career. I mean, it was kind of the area I'm in was kind of stagnant for years and years and years. And now this stuff is blowing the roof off. So, yeah, I'm very excited for breast cancer, both receptor positive and receptor negative. We got some weapons coming out. My first wife passed from triple neg. So, I'm very familiar with the struggle.
Thank you for sharing that with us, Dr. Kiser. Pam, you've also had a few Cerianna PET scans. Can you tell us about this FES-PET?
The FES-PET scan is huge in terms of making a big difference in treatment. I've had it twice, and both times it enabled us to know exactly what I needed to do, that the progression that I had was still ER positive. As we all know, breast cancer is tenacious and smart, and it changes. It starts at ER positive and then can become HER2 positive or triple negative. And so treatment of breast cancer is challenging because of that. And until the FES PET scan, as Dr. Kiser was saying, we would not, when I had my first progression, we would not have known what to do. And all of the progression, every tumor was ER positive, progesterone negative, and there were no tumors that were estrogen negative, so to speak. That's how the report says.
Fantastic.
And so we knew exactly that we needed to change my therapy, but we knew that we still wanted to treat ER positive. And so we switched my treatment. And then just last year, I get scans every 3 months, bone scans and CT scans now, because Medicare won't pay for PET scans anymore for me for some crazy reason. Anyway, that's another whole story. But so I've been getting CT scans and bone scans every 3 months. And last year I had progression. The CT scan showed bone fracture in T11 and T12. And it was unclear whether there was a tumor there. It just was, they weren't sure. And so I asked my oncologist if MRI would give us any more information. And he said, that's a great idea. Yes, let's do it. And I had the MRI, and the MRI certainly showed the fractures, but it showed 3 Mets, or 3 small tumors, that the CT scan did not show. So Dr. Kiser, I want to understand that in a few minutes. So at that point, the new tumors were not, first of all, were not in areas that could be biopsied safely. We really didn't want to do it. And we could do the FES. And we did the FES PET scan, and it showed 4 tumors. One was smaller, and that they were all estrogen positive, and that there were no tumors that were estrogen negative. So again, it saved us in case of trying to decide whether to take the risk of a biopsy, which all the collateral damage that can happen with that. And then are we going to try to do all of them, all of those things? And again, it changed my treatment, because we knew I was still ER positive, but the breast cancer was getting smart for the treatment that I was using at that time. And so we switched my therapy, and it just makes a huge difference.
And you can feel confident in what your therapy is, knowing that you are 100% ER positive. Or if things didn't light up right through the FES Cerianna PET, that would tell you, okay, well, the MRI showed this, but this isn't lighting up. So therefore, it might not have those receptors. So how do we respond in that regard?
I mean, it's a game changer.
Dr. Kiser, I wanted to just ask to make sure I have a clear understanding too. Is FES-PET normally something that would coincide with an FDG-PET, so you see where all the tumors are and then to know which ones are ER positive, or are they independent of each other?
Well, ideally, Just going back to Pam's issue, getting authorization for these scans is very difficult. Like Medicare says no, Aetna says no, Anthem says no. And some of them even think that PET scan in general is still research. It's not. It's been in clinical use since 2000. They had 10 indications for FDG. No, but if you can somehow get both scans, it's very helpful because, like I said, FDG is super sensitive, but it's not specific to ER positive breast cancer. So if you see stuff like lighting up in bone on FDG and it looks like tumor or metastases, and it doesn't light up on FES, then that tells you right away that that tumor no longer has the receptor, and hormonal therapy is not going to work anymore. So they work in tandem very well, but it's hard enough to get one PET scan, let alone two PET scans. But we do the same thing for other types of cancer, where we have a specific thing for like a neuroendocrine cancer, like carcinoid, but you get additional supplemental information from FDG. So we got these two different scans that provide different types of information. Ideally, it would be great to be able to have both FDG and FES because FDG is kind of like a seek and destroy thing. It's like it's going to find tumor as long as it's metabolically active. I have to clarify that to some degree. I don't know which type of tumor you had, Pam, if it was invasive ductal or lobular, but invasive ductal. So invasive ductal is a little bit more aggressive. Lobular is very indolent, and about 20% of breast cancers are lobular. And they tend to be very inconspicuous on mammography. They just kind of they respect all the stuff inside the breast, the fibroglandular tissue, and just kind of grow along it. Whereas, invasive ductal usually presents as like a star-shaped mass or something, or you start seeing this architectural distortion where it starts puckering the breast tissue. But the thing about lobular, the best weapon for that, as far as finding metastatic disease, because it's very indolent and it's not metabolically active. So it's almost, you can't see it with FDG because it doesn't use a lot of sugar. But 80 to 90% of lobular cancers are ER positive. And so I had a case of a woman that got staged because she had a sentinel lymph node biopsy, and it was positive, it was ER positive, but they went ahead and did an FDG scan, and I couldn't see anything. Nothing lit up at all. I said, you've got to do estrogen receptor study. And we found, this is a crazy case. So the primary inner breast lit up, an axillary lymph node lit up, and then she had a metastasis to her eyelid or behind her eyelid. It was the craziest case I've ever seen. And we didn't see anything like that on FDG. So you got to know the aggressiveness of the tumor, what they call the histologic grade. So globular tends to be a little bit kind of slower growing, just kind of chills out, but it's still doing some badness. Invasive ductal will kind of start kicking up some action, making things bad, and it goes bad fast, depending upon the aggressiveness and what to, like your if you're hurt, not your receptor status, or if whatever, like the BRCA gene and all that kind of stuff. So that's the big difference. So, but just to clarify, one of the things that Pam brought up, all these the classical imaging modalities, CAT scan, X-ray, MRI, they're mostly what we call anatomic imaging. It'll show you abnormalities, but it doesn't really characterize them, so to speak. So you might see a nodule on a CAT scan. Well, that could be almost anything, right? So the reason you couldn't see it on the bone, on your CAT scan, the metastasis on the CAT scan, is it has to do something to the bone. If it's just kind of infiltrating and insinuating between the bony spicules in there, you're not going to see any bony destruction, so you can't call anything. That's the beauty of the functional imaging that we do with PET or nuclear medicine, is we're able to see the function of that tumor or the receptor status of that tumor. And I know this is off subject, but the game changer for men's prostate cancer has been this new agent that we have that is changing stage all the time. It's like if you do conventional imaging, bone scan and CAT scan, we're finding stuff that nobody else is picking up, like the CAT scan or the bone scan. So it's just so frustrating that insurance won't cover these PET scans because there's so much more patient information and management information you can get with these things. So
yes, I think the whole getting insurance to cover these things is a whole other topic and a whole other podcast, because we can all get on our soapboxes about that, which is so frustrating. But I think at the end of the day is to ask and to let people know and advocate, like, in case you did not know, there's this other type of PET scan called FES or Cerianna PET that will show if your tumors are ER positive, have ER positive receptors, and that can help inform treatment. And so I think that's really, like, as you were mentioning, Dr. Kiser, like a game changer. One thing that I'm noticing is a lot of pharma companies now are offering opportunities for patients and healthcare providers to call and get support on the reimbursement process. So GE actually has a support line that your healthcare provider or you as a patient can call and get support Monday through Friday, 8 a.m. to 6 p.m. Eastern, and speak with someone about that reimbursement process. So their telephone number is 833-946-6392. They also have an email address. If you want to email, they can be reached at gehealthcare@pharmacord.com. So again, as patients, we are always dealing with financial toxicity and the financial burden of our diagnosis, let alone having to advocate for screenings and various tests. So this is just one other opportunity that we have to be reimbursed for the high cost of dealing with a breast cancer diagnosis. Pam, for your experience too, like, you can feel really secure that you're being prescribed a regimen that is targeting very specifically your type of tumor cells.
Right. And I want to go back to the tumors that the MRI saw were soft tissue, not bone, that the CT scan didn't see. And that's, how does that work?
Usually, so I'm sure you got X-ray dye with your CAT scan, right? They gave you contrast.
Yes.
Sometimes if they don't have enough like vascularity, so like what we're doing is we're lighting up like tiny little vessels and they enhance above other things that are not tumor. If they don't really have that on CT scan, you may not be able to see it, but MRI is a completely different modality. It doesn't use, it's hard to explain, not get too technical, but CT uses X-rays. And so where you have detectors, but MRI is using magnetic currents, or not currents, but magnetism. So we have different, what we call pulse sequences that will bring out like the things like nasty things tend to be brighter on T2. So like tumors that may have more fluid content in them will show up on this T2 pulse sequence. And the normal tissue shouldn't have that, right? I mean, I'm giving a very, very, very broad generic explanation because there's way more technical than that. And I don't do MR anymore. I haven't done it for almost 10 years. And so my MR physiology is a little rusty, but that's basically the thing is you're taking advantage of different tissue characteristics and trying to pull that out with using different types of sequences. So MRI is nothing at all like CT scan. There's no there's no radiation with MRI. It's just magnetism.
What should we be asking for if we're living with metastatic breast cancer and most of us are getting bone and CT and maybe PET scans? I hear very few that are getting MRIs. Should we be getting more MRIs, or are bone scans and CTs enough for MBC patients?
That's almost getting a little bit too clinical for me because it depends on what the clinical scenario is. Like, so you come in, you're a newly diagnosed breast cancer patient, you have a positive biopsy and you have a positive sentinel lymph node, then they're going to stage you up one way or the other, either with CT chest, abdomen, pelvis, or CT abdomen, pelvis, and bone scan or something. And I honestly can't speak to that because I'm not a medical oncologist. But that being said, I was very involved when my wife got diagnosed, and she had to have a MUGA scan because they're giving her adriamycin, and she had a bone scan. And so I don't do planar bone scan, which is like two-dimensional imaging. I've turned my department so all our bone scans are done three-dimensionally. It's called SPECT. And so I actually had to read, her SPECT scan, and I saw something in her spine. I was like, oh my God. So we went and got an MRI because that was the problem solver in that point. And it turned out it was just some disc disease. They say that bone scans are super sensitive as well, but they're not specific. So you can have like arthritis or degenerative change and all this kind of stuff. And I couldn't tell from the bone scan what she had, even though it was a SPECT CT. So we did an MRI and it was completely clean, which was great. But so MRI typically is brought in as a problem solver in that situation. The conventional ways of imaging and staging breast cancer is bone scan and CAT scan. Now, if they have suspicion of distant disease for whatever reason, like using tumor markers or something like that, which again, that's medical oncology, that's not me, then they might go ahead and preemptively order an FDG scan because they said, well, the tumor is super aggressive in the breast. We're concerned of distant disease, and we're going to try and find everything. We don't care about the receptor status. We just want to stage this patient, see where all the disease is. And then they might turn around, if they can get it, to an FES scan if it's ER positive tumor. But again, I'm not going to speak like a medical oncologist. It's not what I do, but I'm having to think like one a lot now because I work so closely with radiation oncology, medical oncology, and pathology and surgery that I'm having to get inside their head a little bit to understand. And these drugs coming fast and furious. And like I said earlier, the drugs that they're using to treat a lot of their cancers, they're putting little radio labels on it so we can inject them into patients and take PET scan pictures of them. So I'm really, it's like, I'm having to become a medical oncologist like peripherally and just to do my job because I have to understand how these drugs work and where they go and what receptors they hit and all that kind of stuff. So it's a very exciting field right now. And unfortunately, my initial training was in internal medicine. So I was an internal medicine physician before I became a radiologist. So this is the perfect marriage of internal medicine and radiology. It's molecular imaging that I'm talking about because we're imaging the physiology of organ systems and tumors and all that kind of stuff. So it helps me. Like when I speak to a cardiologist, I can understand what they're talking about. When I speak to an oncologist, I can understand what they're talking about. So it was like at first I was like, sorry that I've spent 3 years in residency doing this, but now it's been like the biggest thing that ever helped me at this point in time in my career.
Pam, Dr. Kiser, this is incredible. I am over here taking notes. I have learned so much from today's conversation. I am really excited. You got me really excited about where nuclear medicine is heading and how these types of scans can really help those of us diagnosed with breast cancer, those of us living with metastatic disease. And when we have uncertainty, we always want to know, why did the medicine not work? Why am I on my next line of treatment? What happened? What is changing? And so with this FES, also known as Cerianna, PET scan, we can actually confirm if our tumor cells have those ER positive receptors. And we can just feel so confident about knowing that we are on the right drugs. And if we're not, then we can make a change of course and work with our oncologist. So again, thank you both for sharing your expertise and your personal experience and helping us to advocate for ourselves. And thank you for taking the time out of your busy schedules to be on today's podcast. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. If you're looking for specific topics or would like to be a guest on our show, please feel free to reach out to me. My email is laura@survivingbreastcancer.org. Until next time, keep on thriving.